Stephen Mansberger and Dr. Venkatesh as chairpersons along with me. And I would request Dr. Venkatesh to please invite Stephen for the first talk.
Okay. We have a few people, Steve, for you. No, we'll build up. So we have Steve here, who's going to start this session with an interesting talk on biostatistics and how it is important for us. So in addition to being a prolific glaucoma expert, Steve has got an MPH from Osho.
Yep,
so he's got very good knowledge on research methodology and how to do quality research. And we have been also involved in studies like antioxidant study and frequency doubling perimetry studies way back in 2000 with Steve. Welcome to AIOC. I'm sure you are having a good time.
Thank you. It's been great to be here, and I really appreciate the organizers for inviting me. I'm a glaucoma specialist in Portland, Oregon, and the goal for this is just to kind of point out what kind of statistics that I see pretty often doing wrong, and then how to get your papers published if you're interested in getting your paper published. So I have no conflicts of interest related to this talk. I hope if you ever get the chance to visit our home in Portland, Oregon, this is the beach where you get these monoliths here in the distance. It's really, really a beautiful place to visit. So I hope you get a chance to come to Portland, Oregon. So these are my topics. I'm going to talk a little bit about the Fisher's exact test versus the chi-square test. Clinical versus statistical significance. We see this quite often with large databases where they'll show a very, very small statistical significance. The analysis of attention to treat versus other. And then some other kind of things that I recommend when you're doing your statistics, such as multivariable. Such as, it's not working. Okay. Such as multivariable analysis with calculated variables, linear and other relationships, and the correlation between eyes. All right, so I have a little bit of a quiz. We don't have a huge group in here, but I have a little bit of a quiz. You have a sample size of 20 patients. What's the appropriate test to compare two categorical variables? And if you don't know what a categorical variable, it's like yes or no, like I have glaucoma, I don't have glaucoma, or I have diabetes, I don't have diabetes. So what's the appropriate test to compare these two categorical variables? Is it a t-test? Is it a chi-square test? Is it a Fisher's exact test? Is it a multivariable linear regression? So that's quiz question number 1. Quiz question number 2, intention to treat. Does that increase bias? Does that maintain randomization? Does it give data when the surgery has no complications? Or does it bias results towards success? I'll give the answer to this. And then the question is clinical significance versus statistical significance. Is the answer clinical significance increases with sample size? Clinical significance means any p-value below 0.05. Clinical significance may change clinical care, or clinical significance increases statistical significance. Sorry about those long words here. So the chi-square test is based on a normal approximation of the binomial distribution. And many statisticians be a correction for continuity is needed. And this is just basically the equation where the chi-square equals the sum of the observed minus the expected minus 0.5 over the expected. And it reduces the size of the chi-square value. And so it reduces the chance of finding a statistical significance. So the correction for continuity makes the test more conservative. But what do we do if the expected values of any of the cells is below 5? So here's an example of a categorical outcome of interest. Do they have pseudoexfoliation or not? We got men or women. And you can see here we have a cell here where the sample size, or 2 cells where the sample size is below 5. What Fisher showed that the probability of attaining any of these values was given by this equation. And I'm not going to go through that. So, and basically what he showed is that your p-values will be off if you use a chi-square with such a small sample size. You really need to use the Fisher's exact test. And so when any of these cells are less than 5, you should use a Fisher's exact test. And it's based on the exact probabilities of the specific distribution. There's no formal test statistic and no critical value. It only gives you a p-value. And previously it was very difficult computationally to perform. And so when I have categorical variables, I almost always just do a Fisher's exact test anyway, because it'll work with all of your analysis. And so if you're writing, for example, statistical code in R, you can just run it with your Fisher's exact test for all of your data. And if your data has too much sample size, it's still okay. It works out the same. So what about statistical significance? For some reason, we made this p-value less than 0.05, and that has just been the tradition for statistical significance for many, many years. And we know that it's easier to get a p-value less than 0.05 if the sample size increases. And there's a couple things that we talk about in statistics. One is a type 1 error. And what that means is that it's significant when it's not. So that can happen when you have a confounder in a large data set, like for example, like let's say you're looking at the association of diabetes with glaucoma, and you think the significance is high, but then you look at that group and there's hypertension in that group, and you didn't control for that large confounder. So the type 1 error can happen, and it really makes a difference if that is going to change care. We also see this with detection bias with insurance data sets. You'll see these huge data sets used, and they'll show some sort of significant level. So this is kind of an example of this, that glaucoma, Alzheimer's disease, and Parkinson's disease were all associated with glaucoma. And this comes from a Taiwanese national insurance database. They had 8 years of follow-up. They had a huge sample size of 20,000 patients. And they used 16,000 controls and 4,000 with glaucoma. And what they found was, if they had glaucoma, the incidence of Alzheimer's was 2.85 out of 1,000 person years. And if they didn't have glaucoma, it was 1.98. So the thought is that if you have glaucoma, you're more likely to get Alzheimer's. But you can see it was really a small difference, just a really, really small difference here. And the p-value was 0.03. So the only reason this became statistically significant was because of the large database. If you had another large database in a different country, it may have the opposite result. Then here's a different paper. It looked at Medicare database. This looked at 126,000 patients, and they used an even number of controls in glaucoma, 14-year follow-up, and the probability of Alzheimer's diagnosis was 0.17, and the hazard ratio was less. So here we have a paper that shows that glaucoma is not associated with Alzheimer's, but both are significant, and they have a small impact in opposite directions. So it just kind of goes again with this issue of statistical significance versus clinical significance. What would you do if you had this database? You would look at the power, you would decrease the sample size, just take a random selection of patients and do some sort of reasonable number of patients. When do these large sample size help you? If you're looking for something like a really rare condition, then maybe these large sample size help you. But in a lot of cases, you don't need this large sample size for many of the things that we do in medicine. So the other thing I think it's important about when you're writing your papers, so there's a certain formula. I'm going to go a little bit more over this in a second. So I'm the executive editor for AJO, for the American Journal of Ophthalmology. I review every one of their epidemiology papers. And so I review something like 40 to 50 papers per year. And the reason I can get through so many papers is there's a little formula for getting your paper published. The first paragraph, talks about what's important. Your second paragraph talks about the literature and what's unique about that literature. And the last paragraph will talk about what's unique about your study. And then the very last sentence of the last paragraph of your introduction will say, how will this change care? And so that's a number of rejections that I'll do is when somebody has something interesting. I just reviewed a paper recently, was looking at antioxidants for causing cataract in children in China. And I rejected the paper because even though the paper was done well, there wasn't anything you could really do about antioxidants in that group for preventing cataracts. And several papers that had already done randomized clinical trials to show that there was no difference. So that's a key part of your writing your papers is how is this going to change your care? All right, so I'm going to switch gears and go to the intention to treat analysis. For any of you that do surgery studies or looking at outcomes from surgery, this is kind of a really important one. And what you do with this is like you'll have somebody, let's say you do, a trabeculectomy, and you're looking at the your new technique for improving your trabeculectomy outcomes, and you have a group of patients that come back at 1 week, 1 month, but they didn't come back at 3 months. And so what do? Is you just remove all those patients that didn't come back at 3 months. Well, lo and behold, you do your analysis, and your result did not work out. I mean, your new technique did not work out. But the problem is you remove those patients from the analysis that didn't come back. And what you should do is you should do an intention to treat analysis where you have statistical ways of taking the data from them and comparing them over time. So in this type of analysis, everybody that is randomized to a group is analyzed in that group. So it's regardless of whether we receive the treatment. So let's say you did a trabeculectomy and you couldn't get the trabeculectomy right and you had to close it, you still do the analysis on this person. It's regardless of their time to withdraw from the study. It's regardless of their deviation from the study protocol. So everybody is analyzed, and the complete outcome data is available for all subjects. It limits the bias and benefit and maintains that benefit of randomization. So here's an example, an intention to treat analysis, a randomized control trial. You've got randomization to either treatment 1 or treatment 2. You've got a group in treatment 1 that for whatever reason didn't get the treatment, and you have the group in 1 that did get the right treatment, and the same thing here in treatment 2. So anyway, you take this whole group and you analyze them as outcome 2, this whole group and analyze an outcome 1. Again, we see this really common in surgery studies where they'll remove patients that didn't get the right treatment or something happened or a complication. There's also another analysis called per protocol analysis. This is not the intention to treat analysis, and they only take the ones that really got the result or the treatment results. So here's an example from AJO. These patients were screened. They implanted 65 of them. One of them, they didn't fail the screening, and then of these 65, 54 completed the 12-month visit, 11 discontinued, and then they only kept 52 in the performance analysis, and they took these other one out. So what you can see already is you've got a large proportion of these patients that are not even being analyzed by this paper. And these were the results with this glaucoma surgery. Their pressure came down, and then it slowly creeped up over time. And you can also see here what they did is they put the number of sample size here, and you can see the sample size dropping as the time goes on. The weird thing is they call this an intention to treat population, maybe to get the paper published, but it really wasn't an intention to treat analysis. So those are the other common, issue that I see with papers that we reject from AJO very commonly. The other common error that I see is, and many of us in the glaucoma world will know about this variable called ocular perfusion pressure, where you take systolic blood pressure minus diastolic pressure and then divide it by intraocular pressure. But there's been several papers that showed that ocular perfusion pressure is associated with glaucoma. The problem with those analyses is they're not controlling for IOP in those analyses. You've got kind of a variable here that's a combination of 3 other variables. And so if you did the analysis and you controlled for pressure, many of those studies showing that ocular perfusion pressure is associated with glaucoma will not show significance, where what's driving this relationship is the IOP. Same thing with corneal hysteresis. Corneal hysteresis is where you bounce a off the cornea. You look at how quickly it rebounds from that blast of air, and you can look at whether or not that's associated with glaucoma. The problem with that analysis is that that is highly associated with central corneal thickness and with pressure. And so again, when you take this corneal hysteresis and you're looking at those papers, a lot of those papers will not control for central corneal thickness and not control for IOP, which are already known to be highly associated with glaucoma. So just be careful with these analysis of correlated variables. The other thing that we see pretty often is linear versus other relationships in analysis. So for our visual field analysis, we use, for decibels, that's a logarithmic scale. And there'll be a comparison of that versus nerve fiber layer thickness, which is not. And so you have to get those both in the same scale. Either you log the nerve fiber layer thickness or you do an anti-log of the visual field, and then you can compare those 2 variables as far as progression of glaucoma. And then finally, the correlation between eyes is something that we see a lot, where people will include both eyes for analysis, or they've done all this work, they've collected the data on both eyes, but they only use one eye for analysis. And there's something called a mixed effects model, which allows you to include both eyes. All you do is you randomize the subject number or the subject name or whatever it is that you're using for that person, and that will control for the correlation between eyes. But if you don't use a mixed effects model, then your data, again, is biased. So just some final recommendations for the statistical analysis. One is I think it's really good to do the analysis yourself, just so you get a feel for what the data is. But you engage a biostatistician relatively quickly in that. Just say, hey, this is what I'm going to do. What do you think? Any problems with this analysis? And they'll give you some great ideas to save you some time. And then do your own preliminary analysis. Many of us will kind of just really jump right into like a correlation analysis or something like that, but really you have to look at your frequency of the data, look for outliers in the data, look for the distribution of the data. Those kind of things are really simple things that you can do with every statistical program, and that will help you understand what the data looks like. And finally, just make sure the data makes sense. Like if you're finding like the results just don't make any sense, go back again to the data and just see if there's something wrong. We've had databases where somebody will make an error and they'll shift the data, and you'll look at the data and you're like, why am I missing 10 results from the database? And you realize that somebody had shifted the database or used an old database. And then writing and reviewing statistics, the analysis should be clear and follow a logical plan. Buy a basic book on statistics. And if you're reviewing papers, if you don't understand the statistics, look it up. But if you still can't understand it, if you look it up, then you can write back to the reviewer or write back to the editor and just say, I can't understand the statistics. You need to, have another person look at this. Okay, so I'm going to give the answers to the quiz questions, and then I'm going to go through a little bit about how to write a good paper. So we already talked about this. This is the N of 20 patients. You have 2 categorical variables. You want the Fisher's exact test. The intention to treat, what that does is it maintains randomization. So that's why you want to do it. It also helps understand if you get dropouts. You also understands what the results would be even with those dropouts. So you don't have this bias for some patients that stayed in the study. And then clinical significance may change clinical care. That's the important part of that. So if you have something that is really a small difference, like we saw with his Alzheimer's papers, that's probably not clinically significant. Okay, so I'm just going to go quickly over a simple framework for publishing papers. 11 plus, yeah, so I think I have 4 minutes. So this is I have no financial interest in this, but this is a book that I love. I still refer to it after 25 years of writing papers. It's called Successful Scientific Writing by Matthews, Bowen, and Matthews. You can probably get it free on the internet. It's really a great book for writing papers. It'll tell you a whole bunch of things about what to do, like what verb tense to have in the introduction, what verb tense to have in the method section, how to write your first paragraph of the discussion. It's really a useful paper. And I kind of mentioned a little bit about this. I've reviewed at least 1,000 papers for AJO, Journal of Glaucoma, and the number one cause of rejection for these papers is it's unclear how researchers or clinicians would use the results. So as soon as I go through this paper's title and go through the abstract, about 90% of the time, that's what I reject it on. I'm not even though it's interesting, there might be some sort of really unusual association with kidney disease and glaucoma. I'm not sure how we're going to use that as clinicians, so I'll reject that paper. Now, if somebody can say, like, there's some sort of hypothesis about kidney failure and that creates a hormone that might be associated with glaucoma, okay, then that paper might pass that muster, but they have to say how this might change care. And then if there's a whole bunch of papers that already talk about this, then I usually reject that paper because there's already a whole bunch of papers that do this. And then finally, if it doesn't follow some sort of hypothesis testing framework. I kind of gave a little bit about this already. A 3-paragraph introduction is key for your introduction. Why it's important is the first paragraph, and why should the reviewer care. The second paragraph is previous research on this topic. You want to expand or refute that information, like they did this study, but this was what this will improve on. And then your third paragraph, the first sentence is why it adds to the literature. Your hypothesis, we hypothesize that our new antimetabolite is going to improve glaucoma surgery outcomes. And then the last sentence is how clinicians or researchers would use the results. And if you do that, you are 90% of the way on getting your paper published. Your methods, the first paragraph should be study subjects and IRB. Again, this book has this in there. Your middle paragraphs tell the story in enough detail somebody can replicate the experiment. And then you want to put yourself in the reviewer's shoes. If they can understand the experiment, then they're going to be following your paper and they know what to do. And then the last paragraph is just your statistical analysis. Results is pretty straightforward. Basically, you put the most important results first, and you put the findings, maybe in the order of the methods. And then the discussion, the most important part of the discussion is the first paragraph. Explain again why you did the study. So you might take your last paragraph of the introduction, and write that as a first sentence of your discussion. And then how, again, clinicians and researchers would use the study results. You're going to put that in the last sentence of your first paragraph of the discussion. The middle paragraphs kind of expand on the major results. And then the last paragraph gives your limitations for the study, and then what would be some future studies that you would recommend in the future. And that's the formula, I think, for writing a really, really good paper. Some other recommendations. When I was in medical school, I was kind of taught to write passive voice because it sounds smarter. Active voice, where subject, verb, object. That is the way you want to write your papers because it's clearer and it's more succinct. I use an idea tree before I write. I'll write a little circle about what the topic is, and then I'll kind of write an idea tree, which is like how are you going to play out this story about this problem that you're talking about? And it helps make your writing much faster. So I hope I gave you some good ideas about how to improve your statistics in your scientific writing. I hope I gave you a little bit of a formula to improve your scientific writing so it gets accepted. And I hope that you send your papers to the AJO because I will be looking at them and I'll be like, oh my gosh, they're following the formula and this paper should be accepted. So thank you very much. And again, I appreciate the committee for inviting me today.
Thank you, Steve. One couple of quick questions. I mean, when you write a paper, where do you start? Do you start with your results methods or you start with your intro?
Yeah, so the question is, when I'm writing a paper, where do I start? And one of my mentors told me that 1 hour in the library can save you 1 month in the lab. So the first thing you do is you go to the library and you figure out whether somebody's already done this. And if they have, then you've got to restart over and do something else. And then what I like to do, the first thing is kind of present it as a poster at a meeting like this, because you'll write your poster out, your abstract and everything like that. And what I tell my residents and fellows is you can't go to the meeting unless you've got your paper written before you get there. It doesn't have to be perfect, but you have to write it. And so what happens is they write the paper, they present the poster at the meeting, and they'll get some really excellent questions about their poster, and then they'll add that to the paper, and literally they'll submit it a week later. So that's kind of another formula for kind of getting them out. So,
what is your thoughts on generative AI, and is there a role for paper writing? Should we use it or not at this point of time?
Yeah, AI. The question is about using AI to help write your papers. I think I'll tell you, I use ChatGPT all the time, but I use it for some sort of kind of creative writing. Like if I need to write an article for my staff about teamwork, I'll tell ChatGPT to write me a 3-paragraph article about teamwork with a quote. It's awesome. For scientific writing, I've never used it because I kind of have a formula here, and I just don't know how I tell it to do all those things to do it. The other issue with AI is you don't know where it's getting its information. And I just be really cautious because at least AJO, they'll look at your paper and they'll say how often those words were repeated in other papers. And if they have all these words are being repeated, that paper just gets rejected even before it gets to the editor. So I would say, AI is an amazing technology, and the quote I heard is, those that don't use AI are going to be missing out. So I think all of us are going to be using AI in the future, but just be careful with making sure that it's not taking, writing from somebody else and then gets rejected. So,
how often have you felt bad for rejecting a paper and then it goes to another journal, even a better journal, and gets accepted and it becomes a real evidence and people are all talking about it?
Yeah. Yeah, it would be embarrassing if I rejected this paper and all of a sudden it gets, lot
of attention.
Yeah, it gets published in a much more prominent journal. And actually the AJO keeps track of that. And I actually don't know what my personal record is, but I have no knowledge of any papers that I've rejected been accepted at like a higher level, journal, maybe ophthalmology. I do have a couple incidences in my 25-year career where I rejected a paper. The author wrote back to the editor and said, hey, he shouldn't have rejected my paper. And then it got sent out again. And one time it got accepted. So I do have that one thing on.
Thank you, Steve.
Yeah, thank you very much.
We appreciate your time and also your trip to India.
Absolutely.
And safe trip back.
Dr. Stephen will be leaving now because he has other engagements. Thank you so much. Nice meeting you. Thank you. Exciting times after this mystifying talk. Exciting times in the glaucoma treatment world now. And I'll invite Dr. Arjit on drug combinations. I think these are now the rule in managing more than mild glaucoma, and he's going to tell you why and is the need real. Arjit is the local boy and also a local host, so it's appropriate that we start this session with him.
Thank you so much, Devin sir. Thank you for giving me this opportunity. So my talk is on the emerging role of FDCs in glaucoma. The question is there a need for fixed dose combinations? So that's the question. Are they required at all? So I'm going to quickly cover just 10 bullet points, and I hope to convince you that yes, FDCs are the requirement of the hour. Number one, if you look at this slide, it shows that the visual acuity and the stage of the visual field, they worsen even with treatment. Always remember this. So this was a study published by Sharma et al. In the BJO, which showed that 37.5% of the patients, they deteriorated one stage in terms of the visual field over 10 years, and around 9%, they deteriorated 2 stages over 10 years. And it's not just a visual field deterioration, the cumulative blindness also increases with time, even in treated patients. So again, the key word is even in treated patient. So this was published in the American Journal of Ophthalmology by Peters et al., which shows the risk of blindness increasing over time. So in this study, 26.5% became blind in one eye, and 5.5% bilaterally blind at 10 years, 38.1% in one eye, and 13.5% bilateral blindness in 20 years. So if you have a look at this, a large percentage of your patients have the risk of going blind even when they are under your treatment. Now, why is this so? The reason for that is there is a drop in terms of either decibels per year or the VFI. So there is a drop of, let's say, minus 1.5 dB per year, or a VFI loss of greater than 5% per year. In treated eyes, they make 19.4% of patients may fall into the group called fast progressors. So this was a study by Abuslim et al., which showed that close to 20%, they are fast progressors. So even though your patients are being treated, they may still go blind. Also, obviously, you know that the glaucoma quality of life is very important. So the GQLI can be affected as the severity of the glaucoma increases. So we have to constantly re-evaluate our patients, set fresh target IOPs, change the baseline of the visual fields, and add or step up medications if required. So that is where FDCs come in. So gradually you got to kind of re-evaluate your patients and keep changing the treatment. In fact, now the modern thought is that glaucoma is not just an ocular disease. It is a sick eye in a sick body. So this was published by Lee et al. In Ophthalmology 2003. So it said that there is an increased risk of death from any cause and from cardiovascular disease in particular in patients with glaucoma. So you've got to think of it as a holistic point, from a holistic point of view. Number two, monotherapy fails in a large percentage of patients. So this has been published in the EGS guidelines that monotherapy fails to achieve a satisfactory IOP in 40 to 75% of the patients. Even way back, the CIGTS had shown that within 3 to 5 years of treatment, 49% of the patients who start with one drug, they require 2 to 3 drugs. So close to 50% of your patients will require a stepping up of treatment. And a step up, obviously, it favors an FDC. Now, what should be the target pressure? Now, the AGS had already put the value of 18 in our minds, the magic number of 18. But if you look very closely at this study, it showed that in the predictive analysis, eyes with average IOP greater than 17.5, they still had an estimated worsening during the subsequent follow-up. However, those with an IOP less than 14, the worsening was significantly less. So maybe, we need to think whether IOP of 18 or less than 18 is enough. Because even if you have a controlled IOP of 17 to 18, 29% of your patients will still show progression. So probably hitting somewhere around 14 or 15, which will slow down the progression rate to 7%, should be the new target. So 14 is probably the new 18. So this is and the only way you can achieve an IOP as low as 14 is if you use FDCs. A single drug achieving such a low pressure, it's odd. Now, the third point, efficacy of the FDCs versus the components. Now, this may seem something very striking to you all, but this was a review article by Higginbotham, where what they showed was that all the FDCs, a fixed dose combination of dorzolamide timo, fixed dose combination of latanoTimo, brimotimo, and travatimo, all of them, they are more effective than the component meds used separately as monotherapy. So usually our thought is if you give two separate drugs with the target IOP is lower, but that's not the case. So the efficacy wise also, FDCs have an edge. Now this is now an established fact. Even the EGS guidelines kind of state that fixed combination preparations may be preferable to the use of separate instillation of two agents. Also, if you add a prostaglandin to an FDC, you achieve a mean of around 5.6 mmHg further drop. So with just 2 bottles, you can achieve a substantial drop in IOP. Now, this is probably the most important reason why we need FDCs, the compliance and adherence issues in the Indian scenario. So this is a guest editorial by Dr. Praveen Revuri, published in 2023, where he showed that in North India, nearly 50% of the glaucoma patients were non-compliant, and Rajurkar et al. In their study in 2017 had also shown that around 50% are non-compliant. But what is alarming is around 17% are totally non-compliant. They don't use drugs at all. So even though you may be prescribing a number of drops, the patients have the tendency not to use them at all. This study by our very own Prasanna, who's sitting here, the slides are very colorful, just like him. So he also kind of, pointed this fact that around 50% of the patients are non-compliant. So that's an amazing number. So it's not just one study, a number of studies have pointed this fact out. And what is striking is, it's not just in India. Even countries like Taiwan, Hong Kong, Israel, they have a very high rate of non-compliance. So that is really something to think about. Also, this beautiful study by Prasanna, again I'm quoting it. So if you look at this wonderful chart, what it shows is that if you purchase, the number of bottles increases to 3, the compliance drops to 60. And if you're prescribing 4 bottles, be sure that the patients are not going to use them at all. It's 100% non-compliant. Now, this is a very, very interesting study from PGI group, where what they showed was that the drugs per prescription were around 2.18. So already the patients, glaucoma patients who were on AGM, they had more than 2 drugs. Also the number of referred patients, look at the average number of drops. Drugs per prescription is 5. And patients receiving FDCs who are being referred are already 40.8. So there is a huge need for FDCs because of the compliance issues, as well as for these reasons, that already the requirement of drugs has crossed 1 in a majority of the percentage of the patients. This is a study by Claxto et al., which showed that if you increase not just the number of bottles, but the number of doses also, the compliance rate decreases dramatically. So if you have 1 dose, the compliance rate is 79%, whereas if you have 4 doses, it's 51%. So FDCs are associated with an improved adherence, and the EGS prescribes the 2-bottle rule. In fact, the EGS says that adherence may be improved by simplifying the drop regimen. And the best way to simplify it is if you use FDCs. So the prescription of more than 2 bottles of IOP lowering eye drops for simultaneous use should be avoided, as it can lead to non-compliance. Now, these issues are very common. Tolerability. Are FDCs more tolerable? So this particular study by Higginbotham et al. Quoted that the fixed dose combination of brimonidine timolol has more favorable safety and reduced ocular allergy profile compared to monotherapy. So not only the patients will become more compliant, the drugs are more tolerable also. Also, FDCs, as we all know, it will reduce the washout. The lesser number of drops you have, the less is the washout. Now, do the FDCs reduce the cost of therapy? The answer to that is yes. So this is a study from a nationally representative US population. So even in the US, there are people who could not afford meds, skipped meds to save, took less to save, asked for cheaper meds. So it's not just a third world problem, it's a problem everywhere. And if we go across to the spectrum to Russia, so this was a study by Petrov in Russia, he also stated categorically that FDCs are superior to monotherapy in terms of cost effectiveness. So again, in terms of cost effectiveness, it's also good. This is something I can see some eminent cornea specialists in the audience. So ocular surface disorders and drop burdens. So we have a large number of patients who present with these kinds of eyes. So it's hard for the patients to use 2 to 3 bottles plus lubricant. So, FDCs, definitely they reduce the preservative load, but again, is back really that bad? And the answer to that is probably no, unless it is dosed more than 4 to 6 times daily. So you should limit it to not more than 4 to 6 times daily. Also, FDCs definitely make MMT easier. Prasanna is going to talk about it. So now if you have 2 FDCs, you can have a total number of 4 drugs, 3 drops per day. If you add other drugs, so you can give 6 drugs, 7 drops per day, or 6 drugs, 8 drops per day. So it has reduced the number of drops dramatically. So over time, a large number of FDCs have come into being from 1992 to 1998 when Dozotimo came, 2001 Latinotimo, 2005 Brimotimo, 2006 Bimatotimo and Travotimo, 2008 Brinzotimo, 2014 brimonidine and brinzolamide, and 2018 a netasudil latanoprost combination. So what's new? And is it really new? The triple drug combination. So a dorzo-brimo-timo combination study was published way back in 2009. However, these have been pursued. So the same combination, another study was published in 2014. Also bimato-brimo-trimo over time, studies published in 2017, 2020, 2022. And brinzo-brimo-timo, this is unpublished data, it is currently under publication, where it shows a dramatic decrease in intraocular pressure from 25.6 to 15.15. So fixed dose combinations are definitely the need of the hour. So if you want to improve your compliance, reduce your cost effectiveness, and all the other 8 points that are highlighted, you definitely need FDCs. Now, some of the newer FDCs are going to come. But if you look at this netasudil latanoprost combination, it kind of mentions here that there are concerns that netasudil latanoprost FDC was associated with significantly higher incidence of adverse events. So probably not all FDCs are good. There are some FDCs which are going to be bad. So you have to pick and choose. So, it makes a strong case for my next speaker, Devendra sir. So he's going to talk about Trisopt. So fixed dose combinations are the mainstay of glaucoma management today and tomorrow. Thank you.
It's amazing to hear such a lecture and very difficult to follow him. But like I said, these are exciting times because after a long time we've had this drug. So a lot of the things, wire loose hai shayad. A lot of the things have been covered. My main emphasis is fixed drug, wire loose hai beta ye. Is the compliance is better and in the less preservative exposure with fixed drug combinations. Here I would request all of you to look at the highlighted points. Just look at the highlighted parts. And with Just to reiterate a few things, fixed drug combinations, the number of eye drops instilled is less, washout effect is less, local tolerability is better, convenience of administration, compliance, and exposure to preservatives. Again, please look at the highlighted ones. 60% or 60% of glaucoma individuals will have ocular surface disease, and they present as hyperemia, tear film instability, stinging and burning and dryness. This has already been covered, but I would tell you where the last one. Again, look at the highlighted ones with the topical CAI, 2018, this came closest, but it failed. And in India, this was bimatoprost, brimonidine and timolol. We are talking about the triple drugs here, because I'm going to be talking about the new triple drug combination. So this one came into, I think, phase 2, came into phase 3 also, but it failed. This was last in 2014, and worth mentioning, it was from an Indian doctor. So the triple drug combination has been developed. I think it's the first, you can correct me, Abhijit, it's the first in the world. Yeah, this formulation we are talking about. And I think the results have been pretty encouraging in my own experience. And we'll have discussion with the others. I'm sure they will agree the results have been encouraging. And it was, the Trisopt of course is the name. And like I said, same things, the reduction in the total number of drops, improved compliance, avoids washout, reduces the risk of OSD, cost benefit, and an ease of adding or another drug. Abhijit, can you tell us about that cost analysis that you did? So quickly. Yeah, take the mic.
490 against individual drugs, you give it in separately, it's around 1000, and if you give 2 + 1, it's around 800. So that's
what he's saying, that the present market value of this triple combo is less than 500, and if you give the 3 ingredients separately as 3 bottles, it would be 1000. If you combine 2 of them as a combo in 1 bottle and give the third separately, it would be what? 800. So I think that is the actual data cost benefit. Please keep that in mind also. So I think importantly, please know that brimonidine, what you're giving otherwise, it may be as 0.1 or 0.2 or 0.15. This one has 0.2. Brinzolamide is 1% and timolol is 0.5. And arguably still, brimonidine will have 0.2 will have the highest efficacy in IOP lowering. So it's the first one. It crossed the phase 3 trials also. Like I said, the last Indian study with different triple ingredients that failed from Meena Menon. This one crossed phase 3 also, and the ingredients I just told you. So it was basically this. The baseline and week 12 was studied, and change from this is the primary efficacy. Secondary efficacy is a change in the baseline at the end of 2 and 6 weeks. But basically, the week 12 was what we were after, but we also studied 2 and 6 weeks results also as secondary. So 10 centers across India, were they scattered all over India, Abhijit? So that's important. It was a pan-India thing. It wasn't one zone, say north or south. That gives you, there is some racial difference in the IOP effect of different drugs in India that we know. So the 10 centers chosen by the company was across India, 200 eyes, and I'm sure the data, Abhijit, the data has built up even more now, more than 200. It may not be this, but of course, many more patients are taking it now. And basically, on 2 drugs, patients included were already taking 2 drugs. That may be in a dual combination or 2 individual drugs. And then also the IOP on these drugs was 22 to 32 in one eye. So this was the inclusion. So 210 subjects. I think we'll skip the rest of the epidemiology figures, but 210 is the number to remember. And the reduction in IOP, as was shown by Aurojit in a line, but I'm showing you in a bar diagram, 25.68. Remember, the inclusion was patients on 2 drugs having 22 to 32 IOP. So that is the average, baseline 25 or 26, And at week 12, remember week 12 was the primary endpoint, it is dropped to 15. Even if you don't get so much result in everyday practice in all patients, still the drop is significant. So we are quoting this study. So it's a pretty, this line has already been shown by Arijit. So 32% at week 2. Week 6 was 57% reduction, and week 2 and week 6 were the secondary endpoints. Primary endpoint was again 86. So I think these are pretty dramatic numbers. These are impressive numbers to remember. The treatment response rate, 18, greater than 18, greater than 20 were 4, greater than 22 were 2, and IOP was 24. So I think the large cluster we were able to get below 18. Arijit said get it below 14. I think below 18 is what we are after in most of our patients. Venkatesh, you would agree with that. We are after less than 18, and I think these are pretty impressive numbers, and a lot of the proportion of patients got it to less than 18. Importantly, whenever you introduce a new drug, yes, you look at the good part, but you are more concerned about the bad part, if at all. So the general well-being of patients, remember it has brimonidine, which can cause lethargy and drowsiness in the elderly. It has timolol, which can have potentially have all sorts of side effects on the body. So the general well-being, this green number or this green color of the pie chart, and by the way, this was not made by Prasanna for a day change. So so most of the patients had a very good general well-being. So that is pretty good. Greater than 95% were tolerating it pretty well. So 92% here, you can see here, and hardly anyone had poor tolerability. Please again look at the blue highlighting. These were what was studied, standard things. So I think let's not go into these. Gonioscopy, anterior segment, perimetry, and ocular signs and symptoms. Adverse effects, like I said, very important when you launch a new drug which has never been seen anywhere in the world also. It's the first in the world, I can say. Please look at the last line of the slide. None of the adverse events, this is adverse event, required discontinuation of the drug or the bottle, and all the reported adverse effects resolved without treatment any sequelae. And what was those ocular adverse effects? They are expected with almost any glaucoma med, were dry eye, burning sensation, redness, and itching. So nothing out of the blue. This is a very, very important thing for me, which was studied in those 10 multicentric study. Reduced preservative. I think these are the two take-home numbers for all of you. So please look at this bar diagram very carefully. If you have to take two figures from this whole presentation, look at this. The 3 drugs which is in the blue, the percentage reduction in preservative is 60%. I think this is very, very important. This still has BAK, but still overall the amount of BAK was reduced by 60% compared to the 3 drugs if you could give individually. This, I think, is the highlight of this whole set of slides that I'm talking about. And you can see that with the when 2 drugs are given and a 3rd drug is added, then it's less than 33. So I think this is doubled the or rather halved the preservative exposure, and 60% reduction in preservative exposure. I am a big believer in preservative-free or BAK-free drugs in my general glaucoma practice. Would that be a good thing to say? So 60% is pretty impressive. So also the good thing is why these 3 drugs were chosen is the complementary mechanism of action. So you can see that enhances uveoscleral outflow, decreases aqueous humor production, increased ocular blood flow, which is brinzolamide, neuroprotective, if at all, it is brimonidine, and overall complementary mechanism, better compliance, reduced preservative, and efficacy. So I think this is what I had, but before Prasanna comes in and steals my show, I will ask Venkatesh to give his thoughts on what your initial experience, if you've used that as a triple drug.
Yeah, we are already using. I mean, I personally, my department is using. I've been closely asking them because I don't see much patients these days. But it looks like it's definitely effective, but we need some time to say how effective in intraocular pressure control. But what you say, the other things are regarding compliance and getting lesser preservative and all that is more of long term to see whether this really works. But definitely it's going to stay, and
Great.
it's going to we're going to see more combinations like this in the future. I mean, it pushes the interest of us and others to see how, because the patients are demanding. The patients want to be even drop free, but if you're going to reduce the number of medications by putting everything into one particular
number
bottle,
of daily drops we are reducing.
they are going to drive the market. Already it's been driven by, to some extent, our customers or the patients. So this is helping us to at least bridge that gap. This particular formula now we have, but in the future we may have more also.
So I think it's been now up close to 5 months, or November, I think we launched it. So I think 5 months is fairly a good time. My own, though I don't have a compiled data, but I think there was initially a problem here in Delhi. I come from Delhi. There was a problem of the availability, because I think a lot of the doctors were writing more and more, so the company could not fill the shortage. But now I think things are better, so we'll be able to get that data. Arijit, what's your one-line experience in those 5 months? Give a mic, please, to Arijit.
Actually, initially, since we were a little bit skeptical as to how the drug is going to work.
Everyone was, including me.
So we kind of used it in patients like neovascular glaucoma already on multiple
More
drops.
secondary glaucomas.
Yeah, so those patients, we could not really understand the efficacy of the drug. But later on, when we started using it in either treatment, patients who've been on 3 separate drops or an FDC plus a prostaglandin, and I've shifted it, I've got pretty good results in patients.
And no remarkable adverse events.
No, as of now, no.
And one line up for the same about from Prasanna. Acha, you're going to go.
I'm sharing my
So
data.
let's have the star of the evening, Prasanna, to show his experiences.
Prasanna will be talking about advanced glaucoma, right?
Sir, advanced glaucoma and MMT, more of 14-week follow-up is also having, sir. 108 eyes. I'll just touch upon that also.
3 minutes.
Yes, sir. Thank you.
Yes, sir. 3 minutes.
Thank you for the opportunity, sir. And as Arijit sir rightly pointed out, sir, in that study, it was done at an urban eye care center. It was done at Coimbatore, and we kept the compliance very stiff. If the patient missed 1 drop in at least 1 month, then the patient was defined as non-compliant. So that was the operational definition. So patients who are on 4 medications, they at least missed 1 drop in that particular 1 month. So that is why we label them as 100% non-compliant. So we were very particular about the study that Alan Robbins sir mentioned. If you miss 1 drop in 1 week, then you are missing 4 times in a month, and that becomes 4 into 12 per year, and that many days the damage will happen. So that was the idea behind doing that study when I was a fellow with my mentor Satyan sir. So thank you for the opportunity once again on advanced glaucoma and MMT. So some of the slides my senior speakers have already covered. So I'll try to keep it more practical with the objectives of these following 5 points. So in India, actually the problem is most of the times the patient presents in the advanced stage. So there is an imminent danger of patient losing their vision. So that is how we see the patients, right? In India, most of the cases are advanced glaucomas, and there are different staging systems which has already been covered based on Humphrey or based on definitions and severity criteria, or if you may be an octopus user. So advanced glaucoma is something that we have a near total cupping with or without severe visual field loss within 10 degrees of fixation. So that is how we see patients in India, and this is in UK and this is in rural South Africa, where you see in UK 38% and in South Africa 45%. And I think India is no less different, and most of us, when the patient presents to us, it's either moderate or it is advanced, unless we are going to strengthen our screening strategy. So if the patient is going to have an IOP of 21 to 25, within 14 years he is going to go into an advanced zone. If it is 25 to 30, it's going to be 6.5 years. If it is greater than 30, it is 2.9 years. So this is a time interval for them to actually go in to an advanced stage, and there are many strong evidences towards advanced glaucoma. Like the strong evidence that is advanced structural and functional loss at initial presentation, a high or marked visit with IOP. So that's why we screen the patients with IOP. The moderate strength, we have disc hemorrhages, thin corneas, even it still has a role. And of course the African race, which we are not worried in India. So there are patient symptoms, there are secondary causes which we have to keep in mind when we are dealing with advanced glaucomas. Again, those are very important, and we assess the patient with structure function correlation, and always a careful inspection going back to the basic sciences, ISNT rule, and structure function correlation with fundus, OCT and visual fields are very important. So coming to this publication of mine, where we published it in AIOC2024, so not only in early glaucomas, but also in advanced glaucomas is where we were using the 10-2 visual fields. But this is something that 3 permutations and combinations I want at least the neophytes to take home. 10-2 is also important in early stages, where the defect will be seen in 10-2 but not seen in 24-2. Whereas you have another combination where the defect will be seen in 10-2 but may or may not be seen in 24-2, and then we have the traditional scenario where the defect will be seen in both. So again, this is a scenario where in traditional teaching it was thought if 24-2 is normal, you always don't do a 10-2, but those thought is changing, and always the structure function correlation holds well for every glaucoma that we see, and these are the 3 permutations and combinations that we tend to see in our practice. Right. So coming up to follow-up and aggressive IOP lowering. So that is what has brought us here to unite us for FDC. So many studies have come. Patients are not progressing, or patients do not progress if the IOP is less. And you can see Ortberg et al., EMGT. Many people have told that IOP, if you bring it down, the patients are not progressing. You can see that there is another study where if it decreased by 10%, each 1 millimeter decrease in mean IOP, the risk of decreased progression decreases. So everything is modifiable risk factors, and that is where we came to medical management, where my previous speakers covered on these slides, which I am going to skip. So if you are going to miss out on the drops, that is when the multiple single drug, multiple drug, double drug, I have no financial disclosure, but I have used Trisopt and the other combination of Dorzox T with a brinzolamide and a single drug of dorzolamide, timolol and a brinzolamide. So if you are going to give this or this, so studies have shown that the patients are going to prefer this for compliance and other issues. Right. So maximal medical therapy, moving on to the second part. So as Devin Tuli sir beautifully covered regarding all these combinations, and the triple drug seems to be working on all these 4 mechanisms of improving the aqueous outflow, the uveoscleral outflow, decreasing the aqueous humor production and whatnot. And this particular study, as Devin sir beautifully covered, where the IOP is reducing from 25 to 15. And these were the study that the company says, which sir has already covered. So let us come back to what we are doing. So this is a multicentric study. I am also on the board. So these are the 6 authors that we are taking it forward, and we are due for the results. So this is my data that I am going to share. The patient size, 107 patients have actually eyes, not the patients, it's the eyes. So the mean age is 61, and the pre-Trisopt IOP, as I would like to call, is 23 plus or minus 9.52. It's up to 33, 35. You can see the standard deviation here. It is plus or minus 9.52, and some of the patients I've also used, change them if they are on 3 medications separately, like dorzolamide, timolol and brinzolamide. I put them into 1 drop, so who I am seeing. So this is an ongoing study which we are doing, and I'm just sharing my half of my data, and the other authors are also compiling it. So the male and female preponderance, gender 47 and 53, and these are the patients. POAG are the predominant patients that are there in our data, and you can see that this is a pie chart of showing the same POAG. Severity of glaucoma, you can see 60%, so 60 eyes, 56.07% of them, we have taken them, or rather in our patients are more advanced. Again, that points out to the data that we were seeing in India, right? So severity of glaucoma were more severe, and those were the higher number of representatives in my data. And this is the pre-Trisopt and the post-Trisopt. So I have classified Trisopt as an intervention, like a trabeculectomy or a tube, right? Just like that. So drugs used pre-Trisopt, drugs used after TRISOP. So, and this is the table, the same data I have represented them in a table. So you can see that no drug meaning that the patient is actually on TRISOP. So this is before TRISOP and this is after. You can see that even bimetoprost have come down, travoprost have come down, and even latanoprost have come down. So no drug meaning, I want you to get the message right, the patient is actually on TRISOP. I put the TRISOP as an intervention. So apart from TRISOP, the patient is not on any other drug. So you can see that certain zeros are there. But some of my patients, you can see, despite them being on TRISOP, they are using dorzolamide and timolol, and I have told them please stop it because that combination is already you are using it, and this is the last follow-up that I got. And then these are the number of bottles before TRISOP and after TRISOP. You can see again 0. 0 meaning I put TRISOP as an intervention. So the number of bottles have come down in the rather 73 is only on TRISOP among the 107 that I showed the eyes. 73 are only on TRISOP, and you can see 1 meaning the patient is on TRISOP and 33 of them are on prostaglandins. I see this number to be a very good number because if you see it pre-TRISOP, it is 31. Post-TRISOP, it is 33. So it is like more or less the same. So it means that we are able to bring them into a single drug, and that is really looking like a game changer, at least the early results. Yes, irritation, there was one who complained that there was irritation in one eye, and duration of follow-up, it's too early to say because I was lucky to start very early, and 5 patients, 2, 4, you can see that I have a follow-up of 56 eyes in 14 weeks. So this is my current data. Still 50 patients are due for follow-up, and this is a follow-up breakup, and this is a summary slide. Out of the total of 107 patients, 46 have attended the 4-week follow-up, and the IOP has come down to 16. So the 23-24 IOP has come down to drop of 8 millimeters, and out of the 107 patients, among 3-month follow-up, 18 have come far. So it's very new, right? So I have only a data of 18, and the graph is proving to be the same that the study has published. From 16, I am seeing a drop of 15, but the standard deviation is plus or minus 6.87. So that was one observation that I noticed from 4 weeks to 3 months. The standard deviation is slightly higher to 6 from 4. So this is the data that they also showed. I am also noticing something same. I think with time, if this improves to 6 month, 9 month, 1 year, 2 years, as Devin sir told, we have to see more how we are going to see this. So this is where I am standing currently with my data. So where do I see an MMT? So I think like MIGS, I think this also is this is already there, but how I see it as a mathematical equation is if there is an advanced glaucoma, no AGM or on 1 or 2 AGM, definitely I would like to put them on an MMT and monitor them. If the patient is on MMT and he is still going to progress, then maybe I will plan for a trabeculectomy or a filtering surgery. If the patient is going to be a cataractus patient, advanced glaucoma, if he is on no AGM or 1 or 2 AGMs, then I may go this route and then take the surgery, or I may go for a direct combined surgery as well, do a cataract and a trab. If it's already a pseudophakic patient with advanced glaucoma, with or without 1 or 0 or 2, then I may go for an MMT and then see how he is doing. Or if he is going to progress, then I will go for a trabeculectomy. So I think MMT or the FDC, the fixed dose combination, this is where I see the role of it. So I just wanted to do a mathematical equation where we'll be inserting them into our armamentarium. And my results as of now, it seems to be similar to what the company is out, but I am waiting for my team members where we are a team of 5 people who are collecting the data as we speak, and we are going to publish the study very soon. So India is going to be a scenario where it is advanced, and we are all seeing patients mostly who are at imminent danger of losing the vision, and we are going to regularly monitor them with 10-2 and with 24-2 along with a GCIPL and an RNFL change with the fundus photograph. And triple drug doses combination is a welcome option to achieve a target IOP along with mostly compliance and cost of therapy, as Abhijit was actually saying. So once again, thank you for giving me this opportunity to share my data and views on advanced glaucoma and MMT. Thank you once again.
Thank you, Prasanna. I think exciting times, like I said, and your last study makes it even more exciting for the future. I think
yes,
we
sir.
look forward to more of the overall
yes, sir.
results from the 5.
All the other authors, yes, sir.
I'll request Abhijit to see if you can have more people. 5 is too less. So try that. You know, they are all young colleagues, and they are all energetic. They are all good. They are all well trained. So try see if you can have at least 10 people add 5 more to this, and it will be really great. We can have a presentation in Pondicherry, and Dr. Venkatesh is going to host us in the GSI Pondicherry in September end. That will be great. Anyone else in the audience wants to share their initial experience of this triple combo? Yeah, please sir. Sir, please आपका थोड़ा सा बताइएगा. Where are you from?
Myself, Dr. Venkatesh from Maharashtra.
Very good.
2 months before only I have started one patient. One I have already operated for cataract and trap combined surgery. For other I have started this tricept. He was on a multiple drug with multiple drops. Now he is happy with single drop, and the other which I have operated is also happy with that. I have started only for 2 patients now only. Another patient he comes for every 3 months. He still has not come. But this patient which I have operated, so in 3 follow-up, he is not happy with that one.
Sorry, what was the last thing? He was not happy.
Happy, he was happy with.
Okay. So all happy, you are happy, patient is happy.
Yes, I am also
So
happy.
3 of them, mind you, I also started very slowly and gingerly.
This is only 2 months started.
Yeah, 2 months. I started very slowly and gingerly. Like I said as a disclaimer, any new drug, we are very careful. But now I think we are writing it more and more. In fact, I like to share, I was in Bareilly about 6 weeks back for a CME, and there one doctor has used about 100. First of all, I don't know, it's not available so much in Delhi. I don't know how so much is available in Bareilly, but he says it's amazing. He has had no adverse effects and very good IOP lowering. And I'm sure, sir, which part of Maharashtra, sir?
Maharashtra, southern part of Maharashtra.
Sir, नाम बताइए ना जगह
Dr.
का.
Venkatesh Malge.
अरे
जगह का उदगीर.
उडगी.
उदगीर, लातूर डिस्ट्रिक्ट.
लातूर बोलिए ना, लातूर समझ जाएंगे.
हाँ.
So I think it's great because you might be catering more to a rural or a semi-rural
Yeah,
population.
it's I am from Taluka.
And
And another one, Dr. Yashodan, he has also started the same thing for his patient.
Twice a day, 2 drops a day. If a patient is putting from a rural or semi-rural background, compliance is good, and the doctor is also sure the IOP should be good. And I think at less than 500, it's
only for me from Taluka place, the price factor is somewhat restricted to all patient. I think the company will decide.
No, you should speak to him individually after this, sir. I'm sure they will help you. Any other thank you for your experience, sir. Anyone else wants to share their experience? So I think I'll just say one thing, that this is the first one. For me, the parameter for a good drug is that if one company has launched it, if another company wants to launch it, then I feel that's a parameter of success. And I was told recently, going through the exhibition today, that the second company, Indian company, is going to launch it probably in the new financial year, April or May. So that will be great, and I'm sure others will follow very soon. So it's a good initiative. Anything else, Abhijit, you want to add? Dr. Venkatesh, anything for you? All right, thank you everyone, and I'll request all the speakers and Abhijit to please come here for
The company's MR and the area manager has come to me. Just I question one thing. When we 3 vials 15 ml, but they are giving 5 ml only in this vial. Why you are so much higher prices for that? The MR also could not answer, and the area manager also could not answer. नहीं बोलिए मेरा सिंपल मैथमेटिकल था कि जब 3 वायल खरीदे गए